So our patient is anaesthetised, we've discussed with our colleagues what we intend to do, and we're ready to start. We've placed a mouth gag in a patient. So we then lubricate the scope from the tip to the handpiece, and it's very useful to use sterile sachets of lube for this. And I'd caution against putting too much on scope, but we certainly need to lubricate the scope so it passes easily through the stomach. Then start our recording even before beginning to introduce the scope. If you're lucky enough to have an assistant available, then it's their job to both introduce or retract the scope as you request. And this helps while you orientate the scope tip. So when we first pass the scope in, we'll pass it into the esophagus fairly easily as the patient will be intubated. Then the scope will naturally go down the esophagus. And you'll see illustrated here in this patient that there's the impression of the trachea, which is completely normal, pressing against the esophagus drapes over it, and also there's some reflux fluid present on the right hand side of this image. So it's very important that we suction that fluid to reduce the risk of aspiration and to reduce the risk of esophagitis if this fluid happens to be acidic. We'll gently insufflate the scope as we pass it down, so that means covering over the hole in one of the two buttons on the handpiece as we push the scope down the esophagus. If it's difficult to insufflate, so if it's a particularly large patient, you might find it helpful to pinch the cervical esophagus gently, or get an assistant to do that rather, so that we can insufflate the esophagus. So we pass the scope slowly down the esophagus, watching as we go for any lesions, gently giving a puff of air by insufflation if necessary. At the thoracic inlet, the esophagus naturally kinks a little. There shouldn't be any resistance to passage of the scope, however. You'll note from this image, the top image, that the esophagus usually has a homogeneous, smooth pink appearance, slightly glistening appearance to mucosa. In the feline esophagus, however, the distal esophagus is pictured on the lower image, and this has ridges, and this is perfectly normal appearance of the feline distal esophagus. There should be no residual fluid. As we reach the bottom of the esophagus, we'll see the lower esophageal sphincter. A normal appearance for this is pictured on the left, so this should be homogeneously pink. There'll be a few folds around this, and it should be closed at approach. Of course, this can be affected by anesthesia, but even in most anesthetized patients, the lower esophageal sphincter will be closed at examination. There should be no narrowing in this region and no resistance to passage of the scope, no stricture at this region either. So some of the abnormal appearances that we can see of the lower esophageal sphincter include streaks or spots, such as pictured here, of erythema or hemorrhage. So this is an esophagitis from acid reflux. Or the esophageal sphincter may lay open, as pictured on the right, or we may see narrowing of the lumen at this point. So to pass through the lower esophageal sphincter is fairly easy. We don't actually need to take much effort in orientating the scope other than to centralize the lower esophageal sphincter in our field of view. We gently insufflate and then apply some pressure to the center of the lower esophageal sphincter. As soon as we're through, we may see gastric rugae. Now, if you don't and you think you've passed through the lower esophageal sphincter, then you simply retract the scope a little, as you may have, or push the scope right into this mucosa that should be opposite you. And you'll see on this image here the normal gastric rugae, and these rugae can be followed towards the pyloric antrum.